Sounds good.
Okay, great. So good afternoon, everyone. Welcome to our Life and Health industry meeting. We have a really full agenda today, so we're going to dive right in. I am going to just want to welcome folks. In terms of housekeeping, I think our attendees should have chat enabled. Is that right, Craig?
Yes, it should be enabled
Okay,
today.
so yeah, we struggled with that just a hair
Yes.
yesterday. So if folks have questions or want to offer feedback, please put a note in the chat and we'll see it. And then I think to ask a question live, please raise your hand and then we'll move you over to the link. So thank you all for joining us today. We're gonna the first item on the agenda is some federal updates. I'm not sure that I have too many updates at this time, except to let folks know that we're very, very closely watching the budget reconciliation process at the federal level and what that could mean for our Maryland markets. I think, and we'll talk about this in some detail a little later on in the agenda, but we know that, you know, it's going to need to be a time where we're a bit fluid and flexible, given some changing, the potential for changes to impact plans for plan year 2026, which of course folks have filed contracts and forms for already. But there's also the potential for some significant, I think, regulatory changes on the horizon that we're also keeping a really close eye on. So with that, I am going to turn it to David Cooney to give an update on our state session laws. It was a really busy session this year in regards to life and health to talk about impacts to form filing. So David, over to you.
Thank you, Commissioner. And yes, I would say there are probably more life and health bills passed by the General Assembly in 2025 than in any legislative session in recent memory for me. So in the interest of time, we're not going to cover every single piece of legislation during this meeting. But I just want to remind folks out there, for a complete summary of the laws enacted in 2025 that impact insurance, we do have Bulletin 25-9, which is our annual summary legislative bulletin, and we just issued that on June 5th. So for my part, I'm going to start by just highlighting several bills excuse me, that impact the content of life and health insurance contracts, since these bills will require new form filings from carriers in the coming months. And then some members of our external affairs team, they'll discuss some other significant pieces of legislation. So the first bill up for me is House Bill 11, Senate Bill 902, which makes a few changes to the existing requirements for carriers to authorize referrals to non-panel specialists in certain situations when a qualified in-network specialist is not reasonably available. First, the bill removes the June 30th, 2025 termination date for chapters 271 and 272 of the Acts of 2022. So this makes changes to the referral process that were previously enacted in 2022 for mental health and substance use disorder providers permanent. The bill also clarifies and further enhances the out-of-network referral process for contracts issued and renewed beginning on or after January 1st of 2026. For example, the referral process now applies to members who are merely seeking mental health or substance use disorder care, in addition to members who have actually been diagnosed with a mental illness or substance use disorder. Additionally, if a member is still unable to access mental health or substance use disorder services through the referral process, carriers are now specifically required to provide additional assistance to the member in identifying and arranging for coverage. Finally, the bill limits when a carrier may require utilization review in connection with a member's request for a referral, and it clarifies that balance billing protections for mental health and substance use disorder care apply for the entire duration of the treatment plan. These changes will require amendments to the description of the out-of-network referral process that is required to be included in the policy forms for all plans that use a network of providers. Next up is House Bill 848, Senate Bill 474, which makes several changes related to the content of adverse decision notices, reporting requirements for adverse decision data, and standards for the availability and identification of individuals involved in the utilization review process. Two changes already became effective on June 1st, 2025. First, the required notice of an adverse decision or grievance decision may now include a unique identifier for the individual who rendered the decision instead of identifying the individual by name. Second, private review agents will be permitted to post their utilization review criteria on the member and provider pages of the carrier websites instead of on the main pages that are accessible to the general public. The remaining statutory changes do not go into effect October 1st, and these include requiring certain information and disclosures to be more prominent on the notice of an adverse decision or grievance decision, requiring the quarterly appeals and grievances data that carriers file with the MIA to be aggregated at the zip code level and to include an explanation for any significant increases in the volume of adverse decisions. And then finally, requiring private review agents to have a dedicated phone number and email address to respond to utilization review inquiries within 2 business days or sooner. House Bill 820 is another utilization review bill that goes into effect on October 1st. This bill focuses on the use of artificial intelligence in utilization review, and it imposes several requirements on carriers, private review agents, and pharmacy benefit managers. The bill includes requirements related to internal oversight and reviews of AI systems for accuracy and reliability, as well as external inspections and audits by the MIA. The bill prohibits AI systems from being used to deny, delay, or modify a healthcare service, or otherwise directly or indirectly cause harm to an enrollee. Entities using AI must ensure that their systems base UR determinations on clinical information and circumstances that are actually applicable to the specific enrollee. Entities must also ensure that AI systems do not solely base their determination on a group data set, do not replace the role of a healthcare provider in the determination process, and do not result in unfair discrimination. Finally, the bill requires the quarterly appeals and grievances reports the carriers submit to the MIA to indicate whether artificial intelligence was used in making each reported adverse decision. House Bill 1007 is the Genetic Testing Protection Act, and it's effective on October 1st of this year. This bill adds a new section 27-909.1 to the insurance article, which governs the use of genetic testing information in connection with life insurance and disability insurance policies. As carriers are aware, there are other longstanding laws related to the use of genetic information for long-term care insurance and for all other health insurance policies other than long-term care and disability. Under 27-909.1, the limitations on the use of genetic information for life and disability are not as stringent as the existing restrictions that apply to long-term care and other health insurance. However, carriers offering life insurance or disability insurance will now be prohibited from using the results of a genetic test to affect insurance rates, the provision or renewal of insurance coverage, or any other conditions of insurance if there is not an actuarially demonstrated relationship between the medical information obtained and the cost of insurance risk assumed. Additionally, carriers are permitted from accessing the genetic data of an individual without first obtaining the individual's signed written consent. And carriers may not condition eligibility or coverage for life insurance or disability insurance on a requirement the applicant must undergo genetic testing or full genome sequencing. If a carrier submits any life or disability application forms for approval that contain questions related to genetic testing, the carrier should be prepared to provide actuarial justification to the MIA to support those questions. Moving on, Senate Bill 773 is a bill that was intended to address the so-called copay accumulator programs that some carriers have implemented to prevent consumers from using prescription drug manufacturer coupons to satisfy cost-sharing obligations under health benefit plans. As enacted, new section 15-118.1 of the insurance article applies not only to manufacturer coupons, but to any discount, financial assistance payment, product voucher, or other out-of-pocket expense made by or on behalf of the covered person for a prescription drug. So for plan years beginning on or after January 1st, 2026, carriers will be required to include any of these types of cost-sharing assistance when calculating the covered person's coinsurance, copayment, deductible, out-of-pocket maximum. The requirement applies only to a covered prescription drug that does not have a generic equivalent, or if there is a generic equivalent, a drug that was previously covered for the individual through prior authorization, step therapy, or some type of formulary exception request. Also, to ensure compliance with federal requirements related to HSAs, the bill does provide that carriers are not required to include the cost sharing when calculating whether the deductible has been satisfied under a high deductible health plan. In order to comply with these new standards, carriers will need to revise filed contracts to either remove or amend existing copay accumulator programs. And one other note, the bill also imposes certain notice requirements on the persons who actually provide the coupons or other cost sharing assistance, but those provisions will be enforced by the Office of the Attorney General under the Consumer Protection Act. Sticking with prescription drug legislation, House Bill 1243, Senate Bill 975, adds a new section to the insurance article, 15-847.2, which is related to specialty drugs administered or dispensed directly by a provider. Under Maryland law, carriers are generally permitted to require that consumers must obtain covered specialty drugs through particular pharmacies designated by the carrier or PBM. New section 15-847.2, however, provides that a carrier may not exclude coverage if a covered specialty drug is administered or dispensed by an in-network oncology provider, and the drug is either auto-injected or an oral targeted immune modulator, or any oral medication that requires complex dosing based on clinical presentation or is used alongside other infusion or radiation therapies. The law specifies that the reimbursement rate in this situation must be agreed to by the carrier and the in-network provider and billed at a non-hospital level of care or place of service. Also, unless otherwise agreed to by the provider and carrier, the rate may not exceed the rate applicable to a designated specialty pharmacy for dispensing that same covered specialty drug. The next bill, House Bill 1355, Senate Bill 641, makes a small change to the mandated benefit for adult hearing aids under 15-838.1 of the insurance article, which was just enacted last year. So effective January 1st, 2026, the mandate is expanded to require coverage when the hearing aid is ordered, fitted, and dispensed by a licensed hearing aid dispenser. And although this may seem like a relatively minor revision, the change will require amendments to existing contracts that are subject to the hearing aid mandate. House Bill 666 creates a completely new mandated benefit for calcium score testing. And this will apply to contracts, again, issued or renewed on or after January 1st, 2026. Under the mandate, coverage must be provided in accordance with the most recent guidelines issued by the American College of Cardiology that expand the scope of preventive services for the benefit of consumers. It's important to note that as with almost all mandates that have been enacted in Maryland since 2012, this new mandate does not apply to non-grandfathered individual and small group health benefit plans that are subject to the essential health benefit requirements of the ACA. The mandate does, however, apply to all other HMO contracts and policies issued by insurers and nonprofit health service plans that provide hospital, medical, or surgical benefits on an expense incurred basis. So this will include grandfathered individual health benefit plans and both grandfathered and non-grandfathered large group health benefit plans. And form filings will need to be submitted to the MIA for all products that are subject to the law in order to amend the contracts to include coverage for the new mandate. Moving along to House Bill 1069, this bill expands the current prohibition on discretionary clauses in disability income policies under 12-211 of the insurance article to apply to all health insurance policies, life insurance policies, annuity contracts, and HMO contracts. The law prohibits clauses that purport to reserve sole discretion to the carrier to interpret the terms of the policy or to provide standards of interpretation or review that are inconsistent with the laws of Maryland. The expanded prohibition applies to policies issued or renewed on or after January 1st, 2026. Now, however, for forms filed and approved through the Interstate Insurance Compact, the applicable compact standards will govern the content and approval of the policy forms. This means the MIA will lack authority to prohibit discretionary clauses in contracts that meet the uniform standards and have been approved by the compact. Currently, all of the compact's individual and group disability income insurance standards and all of the group life and group annuity standards prohibit discretionary clauses. On the other hand, there is currently no prohibition on discretionary clauses in the individual and group long-term care insurance standards or in any of the standards for individual life insurance or individual annuity contracts. For those types of products, discretionary clauses will be prohibited only if the form is filed directly with the MIA. And note that HMO products and most other types of health insurance products are not even eligibly filed through the compact, so this will not be an issue for any of those contracts. The last bill I'm going to cover right now is House Bill 102, which makes modifications to Maryland's Family and Medical Leave Insurance Program, also known as FAMLY. It delays the start date for required program contributions to January 1st, 2027, and for benefit payments to a date that will be chosen by the Secretary of Labor between January 1st, 2027 and January 3rd, 2028. The MIA has been working closely with MD Labor over the past 2 years to prepare for implementation of the private employer plan option under this program. Since the program start dates were all pushed back under House Bill 102, the MIA and MD Labor are also pushing back some of the preliminary implementation dates for the private option. MD Labor has indicated that they are currently anticipating that approval of the equivalent private insurance plans, also known as EPIPs, will occur in 2027. And so MIA and FAMLY are working together to draft policy templates and a bulletin that will give carriers specific instructions on when and how to file the insured products for the program. The MIA is leading the drafting process for both the policy template and the bulletin, but will be meeting with FAMLY on a recurring basis to seek their input and final sign-off. Once FAMLY is signed off on the policy template, MIA will share the template with carriers for review and comment before we issue any bulletin associated with that. And then as far as the general MIA filing process goes, these filings will be considered health insurance and will be reviewed against both family laws and the insurance article. Filings from all carriers will be required to be submitted to the MIA by a specified date and will be approved all in one batch. We're still working out the timelines with the delayed implementation, but right now we're envisioning a September 2026 filing date. Once the filings are approved by the MIA, they'll be considered approved as EPIPs for the purposes of the FAMLY program, and there will not be a second review of the forms by FAMLY. However, if FAMLY does require a submission of a declaration of intent from employers who want an EPIP, that process will be handled entirely by FAMLY, and the MIA will not be involved in the declaration of intent process. The MIA filing bulletin will also instruct carriers on when they can begin quoting plans for employers, and marketing or quoting of fully insured EPIPs is not allowed prior to the time that will be noted in the bulletin. And we have already heard anecdotally that some carriers may require an employer to purchase another type of insurance or some other service from the carrier in order to purchase an EPIP. So we just want to definitely remind carriers and much keep in mind the prohibitions under 27-214 of the insurance article with respect to tie-in sales. And with that, I think I'm turning it over to Jamie Sexton.
Thanks, David. I do see that we have a question from Caitlin.
Caitlin, can you hear us? You should be able to speak at this point.
And it looks like you're muted, so I don't know if you're trying to get off mute. Maybe in the meantime, while we're waiting on Caitlin, it does look like we have a question in the chat from Rachel Clark asking about the timeline for form filing checklists to be updated.
Sure. So if that's a question about just the checklist in general for all the 2025 legislation, typically because those filings have already been submitted that are for products that go into effect in 2026, the updates will be handled directly within the form filings where you'll get specific instructions from the form analyst as to what needs to be changed. The checklists themselves, they'll certainly be updated for the next plan year. And I don't know a specific date offhand of when the current additional changes are going to be added to those. But because, again, we've already received those filings, you'll get direct instructions from the individuals reviewing those filings.
Thanks, David. Caitlin, are you able to get off mute? We can't hear you. Okay, if I think we'll move on to the next question, and which is from Glenn Arrington.
So with regard to the family medical leave insurance, you mentioned about a bulletin for carriers about tying in. And there are some carriers that exclusively provide that service, but other carriers in the market were asking to have another line of insurance. What does that mean? I don't understand what that tie-in bulletin or section regulation is.
Sure. So 27-214 of the insurance article prohibits a producer or insurance company from essentially requiring an individual to purchase one product in order to obtain the other product. So there may be some nuances to it, but that's essentially what it is. Carrier A could not say we will only sell you a family product if you also purchase this secondary product from us. And again, the statute, you can access that online. And if after looking at it, you have any additional questions, or if you're seeing anything where that's occurring, we would certainly like to be aware of that.
Yeah, I was aware of it because carriers were quoting it and requiring it here in Maryland before everything went to a different date. So, okay, that's interesting to hear. Thank you.
Right. Thanks, Glenn. All right, Caitlin, one last time, and then I think we may, if you want to ask your question later or via email, that's fine too. Okay. All right, Jamie, you're up. So that wasn't all the bills that passed last session. We have more. Jamie's gonna talk about some of this.
Thank you so much, Commissioner. Good afternoon, everyone. Well, David hit on the exciting ones, I think, for the purposes of those of you that are on this call today. There are a handful of others that we wanted to ensure on your radar. As David mentioned, we did just issue our bulletin last week that incorporates summaries of the insurance-related bills from this session. So I would encourage you to take a look at that. I believe that one of my colleagues is going to drop that link into the chat for you if you haven't already seen that. Hopefully you are on our distribution list and have already taken a glance at that. As David mentioned, there is a lot greater detail in that bulletin that we may be covering here today. So please take a gander at that when you have the chance. So we will start here with House Bill 974. This deals with preventative services and high deductible health plans and enforcement authority. This bill amended 15(1)(a)(10) of the insurance article, which requires carriers to provide coverage for preventative health services without cost sharing, consistent with federal recommendations and guidelines in effect on December 31st, 2024. To implement the bill, the commissioner can adopt necessary regs consistent with federal statutes, rules, and guidance in effect as of that date or later to enhance the scope of preventative services for consumers in the state. Alternatively, the commissioner can adopt regs to require that carriers cover future preventative services without cost sharing per recommendations and guidelines issued after December 31st, 2024. Of note for this bill is that notwithstanding future changes to federal regulations and guidance, carriers subject to 15(1)(a)(10) are required to continue covering the COVID-19 vaccine without cost sharing in accordance with the Advisory Committee on Immunization Practices, which is also ACIP. You're going to hear me use that acronym later. Recommendations as of December 31st, 2024. That includes vaccines for healthy children and pregnant women. I know that we've received a couple of questions along those lines, so we just wanted to make sure that we noted that. It is also included in our bulletin. Next up is House Bill 1315. This is vaccinations by pharmacists and health insurance coverage for immunizations. This amends 15(8)(17) of the insurance article to alter the childhood and adolescent immunizations required to be included in the minimum package of health wellness services in certain health insurance and nonprofit health service plan policies to specify that they are those that are recommended by ACIP as of December 31st, 2024. Similar to the last bill, it also specifies that the commissioner may adopt regs necessary to carry out the amended requirements consistent with federal statutes, rules, and guidances in effect on that date, December 31st, 2024, or at a later date to account for any new vaccines recommended by ACIP afterwards. Also similar to before, notwithstanding any subsequent changes from federal regulations and guidance, carriers subject to 15(8)(17) will continue to be required to cover the COVID-19 vaccine in accordance with recommendations of ACIP as of December 31st, 2024. This also includes vaccines for healthy children and adolescents. Our agency will obviously be monitoring CDC recommendations and changes therein going forward. Next up is House Bill 297. It deals with the state-based young adult health insurance subsidies program. This amends a few sections of the insurance article to make changes to that program, including changing the name and repealing the termination date, which makes the program permanent. It provides that MHBE may not implement the program for calendar years in which funds for the distribution of the state health insurance provider fee assessment are not available. For calendar year 2026 and each calendar year afterwards, it allows MHBE, in consultation with the commissioner, to designate funds for the MHBE fund to provide annual subsidies to young adults who meet the program's subsidy eligibility and payment parameters. The bill specifies those parameters will be established by MHBE in consultation with the commissioner. Next up is House Bill 1351. This deals with provider panels. This amends 15.112, the insurance article, and adds a new subsection that specifies that within 60 days after receipt of a completed application submitted by certain behavioral health providers, a carrier must accept or reject the application for participation on their provider panel and send written notice of the acceptance or rejection to the address listed on the application. A list of those that this requirement applies to applications from can be found in our bulletin that David mentioned and that my colleague dropped into the chat. Next up, it's House Bill 936, deals with cancellation and non-renewal of coverage required notices. This amends 15.12.12 of the insurance article to require that carriers send notice of cancellation or non-renewal of coverage of a small employer health benefit plan to each enrolled employee delivered by electronic means, in addition to the written notice that's required under current law. That notice has to require information on additional health benefit coverage options, including continuation through COBRA if available, and plans available through the exchange. And then last but not least is Senate Bill 956. This deals with Med-Sup policies. It adds 15.922.1 to the insurance article to require that carriers pay the same commission rates to an insurance producer for the sale of a Med-Sup policy, regardless of whether that policy is sold during an open enrollment period or within 30 days following the birthday of an individual enrolled in a Med-Sup policy. As I mentioned, we went through that very quickly. David also covered a lot of information, and Riley is going to talk about a few pieces of legislation that created some work groups that the agency is involved in or leading. So if you have any questions, feel free to reach out if they come up after today, or if you have any questions as you review that bulletin.
Great. Thanks, Jamie. So Glenn did put a question in the chat, and Craig, if you could move him over too, since he has his hand raised. But while that's happening, I will start to answer the question. So for the young adult subsidy, it is the language of the bill subjects it to available funds. So it comes from funds that come from the 1% assessment on carriers. Those funds have to be available for it to be implemented. But there is actually another state subsidy bill that passed this year, House Bill 1082. And Brad's going to talk a little bit more about that. And maybe when he talks about that, he can hit on the interaction and the design of that. But I think that's a little bit of an ongoing conversation.
Well, thank you for that. Can you all hear me?
Yes, yes.
So related to the individual market and the small group market, so it's kind of after she talked about that. One of the biggest concerns I have, I'm an insurance broker in Bel Air, Maryland. My company's Group Benefit Strategies, LLC, is that the cost of the individual market is actually lower than the small group market. And some of the small group clients that I have will purchase a group plan in small group under 50, and they're not required to pay anything towards a premium, but some of them pay maybe 50% towards the premiums. But sometimes during open enrollment for the individual market, a consumer that's on a group plan, small group plan, will look at the cost and choose to buy an individual policy through CareFirst. And then me as an agent goes to disenroll the client's employee off the plan. And CareFirst is the only insurance company that will not allow that to be a qualifying event. They require that person to stay on the plan until open enrollment. And frankly, I think that's preposterous. You should be able to disenroll from a plan that may be more expensive and buy an individual policy on the open market and pay a lower premium and not be penalized by the insurance carrier, they're the only carrier that does it. United doesn't do it, Kaiser doesn't do it, and Aetna, when they were in the market, didn't do it. So somebody needs to figure this out, because I was ready to go to the MIA today about it, where one of my clients was going to be forced to retro back and enroll and pay premium when they purchased an individual policy. So it's kind of related to this, but I just need you all to be aware of that. Any other carrier, you submit a disenrollment and no questions asked, you just disenroll them from the policy. So during open enrollment for the individual marketplace. So I just wanted to make that comment on the record, and we need to have maybe a follow-up from that, please.
Yeah, Glenn, so thank you for flagging that. I would say, first of all, I would love to follow up with you separately and discuss that in more detail. But I don't know, David, if you had any initial thoughts you want to share on this call, or if we should just take this one offline and talk more.
Yeah, I think just take it offline and talk more.
Okay. Okay, great. Thank you for raising that, Glenn. Okay, so we have a few things going on in the chat, Jamie. A popular update. We have a thank you from Brad Mainster about support for HB 956. Thank you, Brad. Tracy Lynn Claggett has a question about the effective date of the Med Subcommission change.
I think Tracy answered her own question. She was spot on. The effective date, October 1. Kudos, Tracy.
And then the last question is from Carrie Benton about, will the commission be the same on any policies written on or after October 1st, 2025?
David, I think that's probably a better question suited for you.
Sure. So the commission will be the same for the same plan from a particular carrier, regardless of if it's during open enrollment or the birthday roll, or, you know, so I'm assuming that's what you're asking.
Okay. All right. Well, if there are no more questions there, I think we can turn it to Riley now for more bills.
More bills. It just doesn't end. Well, thank you, Commissioner Grant, for the introduction. My name is Riley Williams. I'm the Assistant Director of Legislative and Regulatory Policy. I will also keep this overview at a pretty high level. I'm sure many of you are familiar with these bills from session and also from the end of session bulletin, which I believe I saw Craig put into the chat a little bit earlier. But we just want to make sure that some of these work groups and commissions that were assigned and created through legislation were still on your radar. So we'll start with House Bill 718, the Maryland Health Insurance Coverage Protection Commission. This commission is composed of members from the Senate, the House of Delegates, executive agencies, industry stakeholders, and members of the public. And the act tasks the commission with monitoring potential and actual federal changes to the Federal Patient Protection and Affordable Care Act, the Mental Health Parity and Addiction Equity Act, known as MAPIA, Medicaid, the Maryland Children's Health Program, Medicare, and the Maryland All-Payer Model. The commission must also assess the impact of such changes and is required to provide recommendations for state and local action to protect access to affordable coverage by December 31st of each year. And it should be noted that Section 2 of the bill, uncodified language, also states that the commission will be effective for 4 years until June 30th, 2029, and then will abrogate with no further action by the General Assembly. And the next bill is House Bill 813, which establishes a work group to study pharmacy benefit managers. This work group requires the Maryland Insurance Administration, the Maryland Department of Health, in consultation with the Prescription Drug Affordability Board, to convene a work group of interested stakeholders and third-party experts in the field of drug pricing and Medicaid. The act tasks the work group to review reimbursements for pharmacists, coverage requirements for specialty drugs, ERISA exemptions for pharmacy benefit manager, pharmacy benefits management regulations, the cost associated with pharmacies contracting with commercial plans versus pharmacies contracting with Medicaid, and provisions of state law regarding pharmacy benefit managers, specialty pharmacies, and anti-steering. Again, this work group must submit an interim and a final report to the Senate Finance Committee and House Health and Government Operations Committee by December 31st, 2025 and December 31st, 2026, respectively. Next is House Bill 995, Senate Bill 776. These acts establish a work group to study the rise in adverse decisions in the state healthcare system. And this work group will be jointly staffed by the Insurance Administration and the Health Service Cost Review Commission, known as HSCRC. The work group will consist of members from the House of Delegates, State Senate, MIA, Maryland Medicaid Program, HSCRC, the Maryland Healthcare Commission, Chesapeake Regional Information Systems for our patients, the OAG's Health Education Advocacy Unit, and other members that will be appointed by the governor. And this act tasks the work group to review existing state adverse decision reporting requirements for all health payers, requires them to develop strategies for and make recommendations to reduce the number of adverse decisions, and to develop recommendations for legislation to address the rise in adverse decisions and standardize state reporting requirements across all payers. The work group also must submit a report with the findings and recommendations to the Senate Finance Committee and House Health and Government Operations Committee by December 1st of this year. And finally here, we'll conclude this section of the agenda with House Bill 939, Senate Bill 674. And these bills requires the Maryland Commission for Women to establish and staff the Maryland Collaborative to advance implementation of over-the-counter birth control. The collaborative is required to study and make recommendations to advance access to over-the-counter birth control and submit a report, an interim report and final report to the governor and the General Assembly by January 1st, 2026, and make a final report in December 1st, 2027. And that brings us to the end of this section. I think there might have been, were there any messages in the chat?
Let's see. So there was a question about appointments for the Health Insurance Coverage Protection Commission. And I put this in the chat, but just I would take a look at the bill. The appointments really depend on the category of person. They really run the gamut. So thank you. Brad Meinster is also commenting on special enrollments. I do just want to say, just maybe for bigger picture, more broadly for folks on the call, I will say that small group market and the health of the small group market and sort of changes that we can ensure that folks have access to affordable coverage for small employers. That's very much on our minds, and it's something that we're actively talking to the exchange about, and I expect we'll be talking with all of you about as 2025 goes on. Let's see, is there any update to when these work groups will begin? Jamie, Riley, anything there?
Yeah, I provide some insight here. So for the Insurance Coverage Protection Commission, that is one that we are waiting on some appointments for with regard to the legislative members. And so that's kind of in a standstill point until we have those appointments. The work group to study PBMs We have been in coordination with the Department of Health, and we are currently in the logistics planning process on that front. We are hopeful that we will start sending out information about upcoming meetings in the coming weeks. The work group to study the rise in adverse decisions, we have an appointment for the House member. We are still waiting on an appointment for the Senate member on that work group. And then that one can begin starting its work in earnest. And then the Maryland Commission on Women, that is not one that we have a leadership role in. We are not staffing it. We are not chairing it. So unfortunately, that is not one that I can speak to very coherently, unfortunately.
There's a question about this, if this will be recorded and available to watch later. Yes, it will. Any other questions for Riley? We have a busy year ahead of us. Busy and exciting year. Okay, moving on to the next agenda update. Brad Bobin, our chief actuary, is on to talk about the state subsidy from House Bill 1082.
Hi, thank you, Commissioner. So as you said, House Bill 1082 authorizes the state subsidy to mitigate the impact of the reduction of the federal subsidy that's scheduled to happen at 12/31/25. As an update, the last set of scenarios were presented at the MHBE board meeting on May 19th. There were several different scenarios modeling the full gamut from full replacement to partial replacement for varying cohorts of individuals. Since that time, the MHBE and their consultants have been updating the modeling to incorporate the latest and greatest information. We have finalized the 2024 reinsurance. That's come in about 20 million more than originally estimated at 639 million instead of 618 million. But that still leaves us with a balance of $450 million at the end of 2024. And so part of the modeling that has been done has been involving the young adult subsidy and whether we can afford the young adult subsidy in addition to the greater subsidy to mitigate the under 1082. And so we have model scenarios for that. And, you know, when we're looking at affordability, we're looking at long-term affordability. So we're looking towards the end of 2028, which is when our 1332 waiver ends. And so, you know, we are projecting things out through 2028. In addition, we've updated things to model out CSR impacts as a possible course of action, given that the CSR funding is part of the appropriations bill and is now something that is on the table. And so the CSR impact of the CSR's impact, the pass-through part of the equation, it reduces pass-throughs because the pass-throughs are driven by the amount of APTC. And by reducing the APTC, the removal of the CSR loading is going to reduce our pass-throughs and make us pay more for our reinsurance program. So for all this modeling, we're modeling out both reinsurance and the subsidy program simultaneously and the interactions between the two of them to make sure that we are accounting for, you know, the net impact of all of these subsidies. The next update in modeling is going to be presented at the July 21st board meeting for the MHBE. They're going to have a recommendation for both the reinsurance attachment point and for the subsidy structure. Any questions? Okay.
Glenn, go ahead. Or Craig, do you need to move Glenn over?
Yeah, so I noticed that that pool has grown tremendously. So it definitely would affect a lot of citizens in the young adult, you know, and the state subsidy program. So, you know, I'm all in favor for it. I'm just saying, you know, actuarially, do you have any statistical information or anything that you can share with brokers that has like a projection forecast of what the state is collecting with that 1% and how it's allocated?
I mean, we have actuarial projections of how much we're spending for our reinsurance program and how much various subsidy programs will cost. I'm not sure that we can share them with brokers. I would have to talk to the actuarial consultants. But yes, I mean, and you know, just to be clear, the 1% only covers a portion of the reinsurance cost. And a large amount of the reinsurance cost is funded by federal pass-throughs, which is the amount of money that we're saving the federal government. So you know, the 1% is you know a component, but the 1% generates well less than 1 year's worth of reinsurance costs. You know, we spent $639 million on reinsurance last year, and the 1% generates about $150 million. So you know, just the reinsurance funding is driven heavily by the pass-throughs.
Right. Right. Makes a lot of sense. Okay, thank you.
Yeah, Glenn, maybe one more thing I'll add is that this will be discussed. So for this bill in particular, we're supporting Maryland Health Benefit Exchange as they work to design that subsidy. They do have some public reporting, which may not be to the specific question you asked, but is pretty detailed, and they're going to be talking about this subsidy at their next meeting, I believe, in July.
Yeah, the last thing I was going to say is I'd asked, how do you apply if you want to be part of one of the work group study committees? And I don't know if I overheard how to apply or what to do there.
Yeah. So each of them, so a lot of the study committees that we put up there all have their some specific processes in the law. So some of them are gubernatorial appointments. Some of them, like the Health Insurance Coverage Protection Commission, has sort of a range of different appointments depending on who, what category of occupation you are. So if there's a specific one you're interested in, I would just shoot Jamie Sexton an email. Sorry, Jamie, I'm putting your email out there. But
No, please do.
yeah, jamie.sexton@maryland.gov. So if you're interested in a specific group, please reach out. And I will say too, if there's not in all of those groups, even if you're not appointed to a group, I would just encourage folks to, if you're interested in a topic, to monitor. They'll all have opportunities for public comment too. And if you're just interested in getting more involved or have specific topical issues that you'd like to talk to us about, just let us know and reach out to Jamie. Any other okay, there's Brad Meanster has a question about getting the CE class, continuing ed classes approved for continuing ed credit. That is one, Brad, that let us take that back because I'm not sure I was aware that this was an issue and a holdup. So I just want to say thank you for bringing it to our attention, and we'll look into that. And if you want to send us an email if there's any more detailed information that you want to provide, that would be great. Any other questions before we move on to Solon and cybersecurity?
Oh, thank you, Commissioner.
All right, go ahead.
All right, my name is Solon Webb, and I'm an examiner for the MIA Market Conduct and Licensing Division. I'm your carrier's point of contact for notification of cybersecurity events, hacking events, security breaches, exfiltration events, in accordance with Title 33 of the insurance article. The purpose of Title 33 is to establish standards for data security and the investigation and notification of the commissioner of a cybersecurity event applicable to carriers. For those of you who may not be familiar, The way to report an event is by accessing the MIA website, clicking on the Insurers tab, then clicking on Cybersecurity. This takes you to an online form called the Initial Cybersecurity Event Notification Form. This form is based on the requirements of Title 33 and of the insurance article. You can also find a link in Bulletin 22-13. The carrier may not have all of the information requested in the form initially. However, the form should be completed to the best of the carrier's ability and submitted within 3 business days from the very first date Maryland residents were identified or the carrier believes Maryland residents may be impacted. And then we will confirm receipt of your event notification and request any additional information by way of email to the carrier's designated point of contact. Our obligation is to ensure that the carriers comply with the requirements noted in sections 33-104 and 105 of the insurance article. In particular, ensuring the commissioner is notified within 3 business days from the very first date Maryland residents are identified, and submitting the initial event notification form within 3 business days satisfies that requirement. Determining the total number of impacted Maryland residents, ensuring we receive a sample copy of the carrier's notice of data breach that's to be sent to the impacted Maryland residents, and the schedule of mailing dates for the notices of data breach. Also, the date a copy of that notice of data breach is sent to the Maryland Attorney General's office to determine if it was sent prior to the first mailing date as required by the insurance article. Lastly, we want to ensure that we receive a copy of the carrier's information security program and a copy of the written action plan. I'd like to emphasize that the meaning of carrier includes third-party service providers, such as vendors, managing general agents, and third-party administrators. Over the past 18 months, the vast majority of the initial event notifications that I have received note that the cybersecurity event occurred with a third-party service provider. If a carrier learns that a cybersecurity event has or may have occurred in a system maintained by a third-party service provider, the carrier should confirm and document that the carrier or an outside vendor or service provider designated to act on behalf of the carrier shall at a minimum determine whether a cybersecurity event has occurred, the nature and scope of the cybersecurity event, the identification of non-public information that may have been involved in the cybersecurity event, and perform or oversee reasonable measures to restore the security of the information systems compromised in the cybersecurity event to prevent further unauthorized acquisition, release, or use of non-public information in the carrier's possession, custody, or control. The insurance industry has always been a top target for cyber attacks, particularly ransomware attacks. In 2024, the average ransomware payment was over 2.5 million. I believe the Change Healthcare ransomware attack ended up with Change paying a $22 million ransom. I expect attacks may increase with the popularity of RAAS, ransomware as a service. With that service, even the most inexperienced hacker can launch a cyber attack. Whether they are successful or not, that depends on the due diligence of the carriers. Thank you.
Thanks so much, Solon. I just want to reemphasize a really important point that was made about who has obligations to report to us under Title 33 of the Insurance Code. And that includes managed general agents as well as third-party administrators. So I just want to emphasize that. So though the reporting is through our insurer tab, it is a broader applicability than just insurers. Any questions? Okay, so I'm going to turn it back to David Cooney for the last couple of agenda items we have.
Thank you, Commissioner. So as a lot of folks are probably aware, on May 15th, the U.S. Departments of Labor, Health and Human Services, and Treasury announced that the departments will not enforce the September 2024 mental health parity final rule or pursue enforcement actions based on a failure to comply with the final rule. The department stated that the enforcement relief applies only to the provisions of the 2024 rule that are new in relation to the 2013 final rule, and also affirmed that the Parity Act's statutory obligations, including the amendments under the Consolidated Appropriations Act of 2021, continue to have effect. This federal announcement, however, has no impact on Maryland laws and regulations related to mental health parity. The MIA will continue to enforce Maryland's parity reporting requirements for non-quantitative treatment limitations under Section 15-144 of the insurance article. And that law expressly incorporates all federal Parity Act regulations found in the Code of Federal Regulations. So until and unless the 2024 final rule is formally rescinded, the rule will be enforced in Maryland. There is one caveat in that the NQTL reports that are currently under review by the MIA applied to comparative analyses performed before the 2024 final rule went into effect. In the MIA's view, many of the provisions of the 2024 rule are consistent with how the MIA had already been interpreting and enforcing the Parity Act under 15-144 of the insurance article. However, we do acknowledge that some of the requirements under the 2024 rule are definitely new and had not previously been required by the MIA. So we're not retroactively enforcing any of those truly new requirements for the NQTL reports that were filed in 2024, but we do plan to begin enforcing those requirements for the next round of reports. Any questions on that item before I move on to the last one? Okay. So my last item on the agenda is just a reminder for carriers to review Bulletin 21-21, which we issued a couple years ago. And it outlines the process for filing certain annual reports that are due from life and health insurance carriers. All the reports listed in the bulletin are to be filed electronically by the applicable due date using the designated email box that's identified in the bulletin. And I want to stress the importance of filing timely, complete, and accurate reports because there's been an increase recently in carriers failing to file some of these reports until after being contacted by the MIA staff following the due date of the report. I just also want to remind carriers that the consequences for not filing these reports may include the issuance of administrative orders and associated monetary penalties. And my staff in the Life and Health Division are happy to assist with any questions related to a particular required report that's listed in that bulletin.
Thanks, David, and thanks, Craig just put that bulletin in the chat. Any other questions or comments from folks on the call or topics we didn't hit that you want to raise? We've had some really great questions so far. Glenn, go ahead.
So I'm part of the Maryland Health Benefit Exchange Advisory Committee. What I found kind of interesting is that some of the carriers are allowing, if they select one carrier, that they can choose from all the different plans. Not that a small group's going to pick, 40 plans from one carrier, but the way it's set up, they can actually do it. And some of the third-party administrators that we utilize here in Maryland for small group don't have the same rules of engagement. So I felt that might have been a little bit of unfair business practices, meaning, CareFirst and small group will only allow 3 plans, United Healthcare 2. And to me, it seemed like, a consumer should be able to use a third-party administrator or the Maryland Health Benefit Exchange, either one, and be able to take advantage of the tax credits, but there shouldn't be some form of a advantage to that. Now, I don't know if it has to do with the third-party administrators not wanting to administer it, but that's not how it was explained to me. So I was just kind of curious, that the carriers, the way I understood it, they only allowed, a certain amount in small group when you use a TPA. So just again, something that I'd like to have investigated and figure out how to make sure that the TPAs are protected and the Maryland Health Benefit Exchange is protected as well on both sides.
Yeah. Thanks, Glenn. So for And I think we probably need to talk offline again about some of the individual arrangements you may be talking about. Certainly like in the individual market. If the employer is getting the tax benefit, then the individuals are not eligible for tax credits through the exchange. But I think so I know that for sure. But from there, I think we may need to talk specifically about some of the
Yeah.
arrangements and
Yeah, I'd
practices.
like to have that conversation. Like I
Yeah.
said, I do understand everything about the individual market too, because I'm
Yeah,
a certified agent through the individual market as well.
fantastic, fantastic. All right, well, we'll reach out separately to set up some time with you for sure. Thank you for your insights. Any other questions? All right, well, I think we're at 2:03, so we're a little bit over. Thanks, folks, for hanging on. Craig will send out just a follow-up if there are questions that weren't answered on this call and you don't know where to go. Please go ahead and Craig will share his email after this call and he can get your questions to where they need to go. Anything else from the team? All right. Thank you all so much for participating. Appreciate it. Thank you.